the topic is about neuromyopathy. In neuromyopathy, I started to focus in this topic since 2 years. And the reason why, because we had actually challenge in diagnosis cases presented with neuropathic and myopathic changes. And some clinicians does have cases with neuropathic changes seen in electrodiagnostic biopsy, electrodiagnostic study. And sometimes they also present with myopathic and neuropathic changes, so they don't know what exactly going on, so they ask for a muscle biopsy. In the muscle biopsy, sometimes we see neuropathic and myopathic changes, and so some of pathology, they don't go further actions because it's difficult to diagnose these cases. So I said, okay, we have to figure out how we can reach a diagnosis if we have cases with neuropathy, neuropathic and myopathic changes. Actually, I started to see a case couple years, 2 years ago in Montreal. That patient was diagnosed, he had a distal myopathy, neuropathic changes, then he was diagnosed with severe denervation. So he went back home, they didn't know what's going on with his case, and then came back again, they did the muscle biopsy, they found the myopathy, then he went back, they said, okay, could be dystrophy. So it was misdiagnosed twice. And again, last time when he came back to us, we did a muscle biopsy, we found neuropathic and myopathic changes, and fortunately, we found some protein aggregation, so we think this is okay, this is something new. So we sent him for whole genome sequencing and come back with myofibrin myopathy filament C type. So what is neuropathy? Neuropathy is a group of neuromuscular diseases with concurrent features of neuropathic and myopathic changes. Seen first in clinical neurophysiological studies, followed by muscle biopsy. The term has never been described in the literatures as a separate entity. Between 1995 and 2018, few papers discussed similar findings in some cases of drug-related myopathy or myositis with secondary neuropathic change. Because of clinical pathological difficulties, the diagnosis of these patients, we created an algorithm approach using a microscopic pathology to make the diagnosis easier for pathologists, and we may reach the diagnosis also for the clinicians. So what we did, actually, we reviewed several sources from Montreal Neurological Institutes in Canada, which there are, these cases are very limited. So we just found 30 cases presented with neuropathic and myopathic changes. Then we also look at the database, mainly the PubMed, and we found also many papers, as I said, with neuropathic and myopathic changes, almost 30 up to my knowledge. Then we confirmed these cases with findings seen in a neuromuscular website to see if these cases actually they presented with a polyneuropathy or a neuropathic changes. So the reviewed cases include patient presented with progressive muscle weakness with a neuropathic change with or without systemic features. Patient showed neuropathic pattern in electrodiagnostic study, which is EMG and nerve conduction study, and or patients, this is the main point, patients showed concurrent features of neuropathic and myopathic change in muscle biopsy. So group A, as I said, and group B was patient with neuropathic and myopathic change, and the last group was EMG nerve conduction test with neuropathic and myopathic symptoms. So these cases, sometimes they're, as I said, misdiagnosed. They don't know exactly what the diagnosis could be neuropathy, could be myopathy. So they go and back. So what they said indicated for those cases who have a long-standing symptoms, or they don't respond to treatment, or they associated with a systemic feature, what they do, they indicate them for a muscle biopsy. So actually, we sometimes find a diagnosis. And sometimes we get a differential diagnosis, and we may push them to do a genetic to find the diagnosis. So we performed a retrospective screening of all cases, exempted age and gender, and almost, as I said, 30 cases. PubMed, we found 31 documented cases with neuropathic and myopathic changes, and finally we confirmed it. We correlated the above findings with the neuromuscular website to make sure those cases actually they present with the neuropathic features. So we use two parameters to know whether we are in the right track in these cases. And actually, we use the histological parameter mainly in differentiating these cases. And we know when we talk about neuromyopathic changes, we talk about neuropathic changes and myopathic changes. Other clinical indicators like inflammation, REM vacuoles, protein aggregates, we found those features are present actually in those cases with neuromyopathic features in the literature, in our cases in the MNI. So as we said, when we say a neuropathy, that we have some histopathological feature for neuropathy. So mainly you see angulated round fibers, five-type grouping, small large group atrophy, and in those cases they show as well in the muscle biopsy the necrotic fibers and regenerated fibers. So then we say, okay, this is a neuropathic and myopathic changes. So we don't stop here. So some of the pathologists, they stop and say, okay, we don't know. The patient should be followed up, or the patient should go to the genetics. But I think what it did, we should focus and to reach the diagnosis. There is a reason that patients present with this bilateral findings. As you can see, this is a feature of myopathic changes. Atrophic fibers, regenerated fibers, necrotic, and vagocytic necrotic fibers. And this is the symptoms, the neuropathic changes: selective atrophy, angulated and round fibers, and we sometimes find also target/targetoid fibers, and fiber type grouping of the neuropathic change. So those cases, the 30 cases, we found them in the year between 2017 and 2018, where they presented with bilateral or concurrent feature of neuropathic and myopathic features. 12 cases of them were clinically suspected myositis and diagnosed finally with inclusion body myositis. And you know, inclusion body myositis can present with polyneuropathy, and they can have some neuropathic features. 5 cases, 5 of these cases, myositis, they are treated. They're treated clinically with a steroid or other medications. Then they come back again. They don't respond to the treatment. So when we do the major histocompatibility and the MAC, we found there is an overexpression of all the muscles. So this could be a treated inclusion by myositis, and this is the reason they already had a neuropathic and myopathic symptoms. The other cases, we have here the cases of oculopharyngeal muscular dystrophy, myofibrillar myopathy type 5, which is the case we found in Montreal. That it was a funny case because 2 times they presented with denervation and the dystrophy, and finally they come back with myofibrillar myopathy after a genetic test. Also, the drug like hydroxychloroquine, they can present with these both symptoms. We reviewed all cases from the other database, and that histologically showed neuropathic and myopathic symptoms. And our main indicator was actually the inflammation. So we classified the neuromyopathy into inflammatory and non-inflammatory types based on the cases, because we have seen like 15 or 16 cases present mainly with the neuropathic and myopathic with inflammation. Then we choose 2 main pathological parameters, which is actually protein aggregates and the REM vacuoles, to subclassify those inflammatory and non-inflammatory myopathy. So what is the protein aggregate and REM vacuoles? Basically, protein aggregate is abnormal accumulation myofibrillar protein in the muscles, They are red in hematoxylin inosine stain and dark blue and purple on gomerotrichome stains. They can be stained sometime with desmin. One of the example is cytoplasmic body, which can be seen in some myopathic disease like ankylosing spondylosis and oculopharyngeal muscular dystrophy. The rim vacuole, a small structure muscle fibers, which is surrounded by some tubular filamentous inclusion, and they can present in many myopathic diseases. So this is an example of the protein aggregates, and this is an example of the rim vacuoles. So what we did actually, so we classified the neurobiopathy into inflammatory and non-inflammatory. The inflammatory subcategorized based on the protein aggregates and the rim vacuoles, and we said, okay, this is the rim vacuole and non-rim vacuole type. So what do we have here? Neuromyopathic change with inflammation. These category described in the literature associated with ankylosing spondylosis mainly, and rarely with fascicular humeral muscular dystrophy and oculopharyngeal muscular dystrophy. So the presence of the neuromyopathic change with active inflammation and rim vacuole is always associated with ankylosing spondylosis. And this is an old school, and we know all of this. So what's supported, we can support it with the filamentous occlusion and mitochondrial dysfunction like COX negative fiber and rugged red fibers. This is the case of occlusion. This is one of the cases of ankylosing spondylosis with neuropathic changes. As you can see here, a lot of angulated fibers, COX negative fibers, mitochondrial dysfunction, rim vacuoles, and some inflammation in endomysial. 49 years. So this is myopathic inflammation, ankylosing spondylosis. Then, so as you can see here, rim vacuole, ankylosing spondylosis, and we have the other fascicular humeral muscular and oculomuscular pharyngeal muscular dystrophy. In non-inflammatory side, we found first we have to use the protein aggregate, then the rim vacuoles. So in cases with a protein aggregate with or no rim vacuoles has some differential diagnosis, mainly the myofibromyopathy. While no protein aggregates, we'll look at the cases with the present with neuropathic, myopathic, no protein aggregates, then we found some rim vacuoles. Let's see. So neuromyopathic change with lack of inflammation, so no inflammation, but shows some protein aggregates with or without rim vacuoles suggest myofibromyopathy. And I have seen 3 cases presented with the same kind of this pathology. If you don't have a protein aggregate but with rim vacuole, then expand the differential diagnosis into different diagnoses that we found actually in the literature: oculopharyngeal, Velander distal myopathy, Emery-Dreifuss muscular dystrophy, and distal myopathy with ADSSL, limb-girdle, and distal dystrophy with rim vacuoles. So here's the trick, because we've seen some ankylosing spondylosis who retrospectively treated with medications like steroid or whatever, and they come back again with no inflammation, but there is neuromyopathic symptom and neuromyopathic features in the muscle biopsy. So how can we do? Basically, we do the major histocompatibility with the MHC and MAC. If they are overexpressed, then we know this is a treated ankylosing spondylosis. The third one, neuromyopathic change with lack of inflammation, lack of protein aggregates, lack of rim vacuoles. That means they only present with neuromyopathic change. We have different cases. Distal type myofibromyopathy, which is difficult to diagnose, as was said. Mitochondrial myopathy in some cases. Paraneoplastic neuropathy, there are 3 cases reported in the literatures, and we had 1 case actually. They usually present with autoimmune necrotizing myopathy, and they show MHC overexpression and CD68 positivity. Amyotrophic lateral sclerosis, drug-induced, mainly hydroxychloroquine and vincristine. Partial denervation atrophy, recently we had 1 case present with neuromyopathic symptoms like denervation and other myopathic feature in the muscle biopsy. And what we found, procellosis in the CSF. This is one of the case This filamin C myopathy, neuromyopathic change, protein aggregates, as you can see here, fiber type grouping, and they are scatter of neuromyopathic and myopathic changes. And we found protein aggregate, but no rim vacuoles, and diagnosed with point mutation in FLNC gene. This patient has suffered for 2 years because he presented first severe denervation, then he came back again with dystrophy-like. Then we found 2 cases reported. Actually, those patients with myofibromyopathy, filamin C, they may present with dystrophy-like feature. Another case, autoimmune necrotizing myopathy, paraneoplastic, 41 years female, had history of breast cancer, presented with polyneuropathic features. They did the biopsy and they found necrotizing muscle fibers and features of neuropathic change, and CD68 positive and MHC, which is autoimmune necrotizing myopathy. This is another case of recently we have severe denervation with minimal myopathic changes. And finally, we couldn't get the diagnosis because it's difficult, because we see just neuromyopathic features and we don't see any protein, any rim vacuoles. Then because the patient has a previous history, then CSF detected a Procella. So progressive muscle weakness is the most reliable clinical indicator of those cases, as we say, as we have seen. Some of these cases presented with systemic features like dysphagia, dysphonia, ophthalmoplegia, cataract, and cardiac dysfunction. CK is single reliable test, but no study has been performed to confirm the association of CK with neuropathic feature. EMG, nerve conduction test, practically they can figure out neuropathic and myopathic pattern. Nerve conduction test also they can use to figure out the concomitant neuropathy in the case. Muscle biopsy indicated those patients with the longest standing symptoms associated with other systemic features, lack of clinical improvement, or inconsistency between the clinical presentation and EMG finding. Because of the clinical pathological difficulty, the diagnosis of those patients with neuropathic and myopathic symptoms or pattern in the muscle biopsy, we did this algorithm, and mainly based on limited observed cases. So this is basically finally how we classify the inflammatory, non-inflammatory rim, as we discussed before, no protein aggregates with the protein aggregates, the rim vacuole, non-rim vacuole, based on the literature and the case we have. The cases are very few cases, and we want to figure out more cases to make this. We cannot make a very pure statistical study on this. This is all the group that they can present with neuropathic and myopathic changes in muscle biopsy, as we discussed in the schedule. Commonly, we see in collision body myositis, those patients present with myopathic and neuropathic features. Also, myofibromyopathy, filamin C type, paraneoplastic myopathy, or autoimmune necrotizing myopathy, drug-induced myopathy, and this is common in the literature. In the literature, you're going to find a lot of cases with neuromyopathic change associated with the drug. The algorithm can help the pathologist reaching the diagnosis in medical institution where facilities are limited. This algorithm can help to tighten and minimize the differential diagnosis and also to avoid additional expensive tests to be done. Also, it can be only used in only patients who are presented with concurrent features of myopathic and neuropathic feature pattern in muscle biopsy.
Dr. Maher, 2 minutes. 2 minutes to go, please.
We may require genetic tests in some cases. So what the future plan we're going to do, we will statistically allocate all the cases in neuropathic change in the summer. So see how many cases we have featured by the neuropathic and myopathic pattern. We will relate the clinical history, pathological finding to be confirmed with the genetic findings done on those patients. We're going to have our, this is just a quick 3 slides. We're going to have our neuromuscular lab attached to King Fahd Medical Research Center. We're going to do a muscle biopsy, and we are preparing for the lab. This is our team, a neuromuscular neurologist, adult and pediatric, and me. We have a neuromuscular scientist, neuromuscular technologist, and also a neurogeneticist. Actually, the center going to be connected with the Neuroscience Research Center. center of excellence and genetics, so we can do genetics. So the service we're going to provide histopathological diagnosis, immune staining, genetic test, neuromuscular research, consultation, and board review. So if in the future you have to collaborate with us, you can send the cases to our lab. Thank you very much.
Thank you, Dr. Maher, for this nice review and excellent presentation. Our next speaker, the topic will be the oligosymptomatic hyperkalemia, will be presented by Dr. Areem Al-Hamad. Dr. Areem Al-Hamad she is adult consultant neurologist, a neuromuscular disorder specialist, King Saud University Hospital in Riyadh. Please, the podium for you.
Thank you, Mr. Chairperson. Bismillah ar-Rahman ar-Rahim. I'll be talking today about minimally symptomatic or asymptomatic presentations of hyper-CKemia. Before starting, I'd like to thank the organizing committee and the Saudi Neurology Society for sponsoring such events and such event and previous events that help us in networking with our colleagues here in Saudi Arabia and outside Saudi Arabia. I have no disclosures. What I'll be reviewing today is the consensus on CK cutoff values beyond which we should call concerning for an underlying disorder. And then I'll go through the suggested approach in terms of ruling out non-neuromuscular, non-myopathic causes. The published series so far showing the diagnostic outcomes and patients presenting with asymptomatic, minimally symptomatic hyper-CKemia. And then we'll go through variables predicting finding abnormalities on muscle biopsy, as well as a few clues on that routine histochemical analysis of muscle biopsy. And then we'll close off by talking about the prognosis and the diagnostic approach at the end when you find either a normal EMG or a myopathic EMG in these cases. So what is CK? A roughly 86 kilodalton dimeric enzyme, which has two subunits, a B subunit and an M subunit. And in different combinations, this would give you three isoforms. MM found in skeletal muscle, MB found in cardiac muscle, and BB found in the brain. Obviously, the total serum CK measured reflects all these three isoforms. And this enzyme definitely has a very crucial role in cellular energy and metabolism. So when we look at the reference data, reference values we get from most commercial laboratories when we test for CK, these are mainly drawn from the central 95% values or observations from healthy Caucasian individuals. And they usually assume that these values are in a Gaussian or normal distribution, which is not the reality. And most of the time, CK values would be skewed towards higher levels. So when we take those reference values from these commercial labs, most of those will give you a level of 0 to 200 international units. And if we just rely on those common reference values, because some of them go up to 300, you will get a very high false positive rate of hyper-CKemia. So an example on one cohort showed up to 19% of men and 5% of women had been labeled as having high CK levels when using these reference values. So in an attempt to identify a better cutoff value or upper limit of normal, Brewster and his colleagues in the Netherlands looked at a cohort of more than 1,400 healthy individuals. And this is what they came up with in terms of the 97.5 percentile value for gender and race. And so they're charted right there. Obviously, we can't apply these to different populations, including ours. And so in order to also go towards a direction where we're trying to reduce the amount of false positives or unnecessary testing, as mentioned by my colleagues before for neuromuscular disorders in general, a level of 1.5 times that 97.5 percentile value was decided on to reflect a level beyond which you would go forward with your investigations. And with that cutoff, that group found that the false negative rates or missing cases with true hypercikaemia, when you're labeling them as normal, is about 0.5 to 1.5%, which is reasonable. Just a few points. Beware transient elevations of CK levels, which can occur obviously after unaccustomed exercise, and the extent of how high the CK would go obviously relates to the duration and the level of exertion. And so it's wise to recheck your CK levels about 7 days post-rest. Another not so common but good to look for cause for false positive high CK values would be a macro CK. And simple words, these are basically CK conjugated with another protein, whether it's an immunoglobulin or an unidentified protein, so type 1 and type 2 macro CK. These can easily be tested for with electrophoresis. Before going into how to investigate these cases, we really want to be sure about what we mean when we say minimally symptomatic cases. So per the European Federation of Neurological Societies, published in 2010, this was defined as cases that lack objective weakness and have these other vague symptoms. Examples written in their reports included fatigue, exercise intolerance, cramps, stiffness, and so forth. So when your cutoff value is above that agreed upon by the European Federation guidelines, and that was used from the Brewster study, you first would like to rule out non-neuromuscular, non-myopathic etiologies. I have here just a few of those causes, non-neuromuscular causes. Obviously, there are more than that, and that would be beyond the scope of this talk to discuss all of them. But some common things worth mentioning are the medications, most commonly statin medications, endocrine disorders, commonly thyroid, hypoparathyroid, and as Dr. Meheza mentioned, post-vaccinations, post-EMG, obviously you can have elevation of CK. Ruling out non-myopathic, meaning it's either neuron, root, or neuromuscular junction disorders, or peripheral nerve disorders, is pretty straightforward with EMG. So when you find a neurogenic units on EMG, thank you, Dr. Maher Kurdi, he made my talk easier. I mean, really be careful to look for subtle myopathic changes, because I mean, a lot of conditions can cause the neuromyopathies, as he mentioned. And so look for those carefully, especially when you have high CK. Myopathic, we'll talk about that later, but when you find normal EMG, again, precaution would be if the patient has symptoms of fatigability proximally, is check for repetitive nerve stimulation to look for limb-girdle myasthenia. So let's say your patient has 1.5 times the upper limit of normal based on Brewster's cutoff limits. You recheck the CK after 7 days, it's still high, and you ruled out a macro CK, your EMG is normal or shows myopathy. What's next? So before we go there, I'll just briefly show you the rates or frequencies of diagnostic outcomes and what has been published so far. So these were actually summarized very nicely in the EFNS guidelines reported in 2010. They included about 8 series published between 1989 and 2008. Before knowing what their diagnostic or specific myopathic diagnoses were, it's good to note that the rates of finding abnormalities on EMG were very variable. they were between 29 to about 74%, and that's understandable. It can be related to the experience of the EMGer, the extent of muscles you would needle, but what is important to note here is that, as Dr. Abuznada mentioned on Thursday, finding myotonic discharges can be really valuable in limiting your testing and limiting your workup. And so instead of doing all of the unnecessary testing, which is costly, might be also a burden to the patient, just finding myotonic discharges can really limit your tests. So I would caution towards doing, being very careful looking for that spontaneous activity. So what did they find in those 8 series? So in summary, the total number of patients evaluated by those studies published were 460 cases. They had a specific myopathic diagnosis in 125, and that diagnosis was achieved in a very wide range through muscle biopsy. So it ranged from 8 to up to 63%. And again, that probably relates to the experience of the person reading the muscle biopsy, the number of special immunohistochemistry staining you would do, or the quality even of the basic staining you would do. Non-specific myopathy was found in about 190 patients. Neurogenic causes were found in 25, and normal biopsies were found in 134 cases. So what were the categories? The most common category was metabolic myopathies, occurring in 42% when we sum up all of these series. And as you see there, expectedly, myophosphorylases, adult onset Pompe disease were the most common. Muscular dystrophy, again, the most common one was dystrophinopathy, so it was expected. But other muscular dystrophies were there, although a few cases, but they were found, like dysferlin, FKRP, caveolin. Inflammatory myopathies can be seen as well. And in terms of the other miscellaneous pathological diagnoses that were reached, I would just want to emphasize a single point about those highlighted myopathic changes that you might see in terms of searching for mutations involving RYR1. And you know why? Is some of these cases might have susceptibility to malignant hyperthermia. So whenever you see those findings, please search for RYR1 mutations. Obviously, not all RYR1 mutations can cause malignant hyperthermia, but it would be definitely prudent to search for that. When we look at the subset of those series that did more comprehensive testing, just to see if you do more comprehensive testing, does that necessarily imply that you would get better rates of specific myopathic diagnosis or not? Those included 3 studies published by Fernandez, Falosto, and Prel. A total of 300 patients, and still, rates of finding a specific diagnosis were not that high, only 28%. Non-specific myopathies in 43%, and a normal biopsy in 29%. After that last study that was summarized by the FNS group, I really didn't find anything published in the literature about diagnostic outcomes in these cases, but this particular series caught my attention, which was published from a group in France. And they looked at their confirmed cases of anoctamin 5-related myopathies in terms of what percentage of cases presented with minimal symptoms, hyperCKemia with minimal symptoms. I was struck by the fact that about more than 50% of their cases actually had that presentation. So they had 38 confirmed cases, and 20 had hyperCKemia with minimal symptoms. And what's more interesting is that a relatively high frequency of MRI changes was found even in that group that had minimal symptomatology. So 11 out of the 18 cases that had MRIs, fatty infiltration of the medial gastric nemus was found. So that would be a very valuable clue. Cardiac involvement, although it was only in 2 cases and the minimally symptomatic group, but it was still would be worth looking for. And the genotype was similar between those two, the myopathic and the the minimally symptomatic cases. What was interesting too is that we usually think of Noctamin 5 myopathies presenting with very high CK levels, or above 1,000. In this series, actually their lower ranges of CK were even 200. So another thing to point out. Moving on to variables predicting finding abnormalities on muscle biopsy. These can be briefly summarized into 3 points: the EMG, CK levels, and age of the patient. EMG, Dr. Aziz Shaybani and his group did a series looking for the rates of finding specific myopathic changes on muscle biopsies in patients presenting with either myopic or weakness or minimal symptoms. And so that subgroup where the patients had no weakness and had a normal EMG, the rates of finding abnormalities on the biopsy was about 50%. That jumped up to 31% with positive EMG. Positive predictive value is 51, negative predictive value is 74 based on Prell's group. The CK levels, it was variable, so between 5 to 10 times, based on different series, would predict a positive biopsy. Moving on to some clues, very subtle clues, even on routine muscle biopsy. But before that, how are you going to choose your site of muscle biopsy? So if you have a positive EMG, meaning you have myopathic changes, obviously you're going to go towards that site where you have myopathic findings. If you have a normal EMG, then I would suggest that you go ahead and do MRI. Talking about those would be beyond the scope of this talk, but some examples were given by Professor Andoni, and I think Dr. Toscano too on Pompei's disease on Thursday. So it's really prudent to do an MRI to help guide your site. So some of the basic clues would be checking a myophosphorylase stain, obviously, looking for myophosphorylase deficiency. Another important clue is, I noticed, especially here in Saudi Arabia, not all neurology pathologists do the Congo red stain. So I would be prudent in asking for a Congo red stain, and that is because sometimes you might see interstitial amyloid deposition, which would be a clue towards either dysferlinopathy or Noctamin 5. And actually in one series published by my colleagues at Mayo Clinic, about 8 out of 13 patients with Noctamin 5 mutations had interstitial amyloid deposition. Another clue would be finding eosinophils and inflammatory collections on the left lower corner here, which would point towards a calpain mutation. And in the right lower corner, you'd see the regenerating and the necrotic fibers occurring in clusters, which might be a hint, it's not 100% specific, but might be a hint towards a Duchenne carrier. So molecular testing, I'll skip that. Prognosis, relatively benign prognosis. So a few studies that followed these patients up to 6 years found that most of them had persistency hypercikaemia, but had really no alternative diagnosis. So for example, in this study, they found only 1 out of the 55 cases that were followed up was eventually diagnosed with a limb-girdle dystrophy, and the other one was another patient was diagnosed with dystrophin as a dystrophin carrier. Is it cost-effective? Definitely, for multiple reasons. Number one, you want to do cardiac screening. Number two, you want to look for malignant hyperthermia susceptibility and counsel patients. So it's definitely cost-effective. Moving on to a suggested diagnostic approach. Based on the evidence available, so it would be class 4 evidence. If you have CK levels above 3 times the upper limit of normal, EMG is myopathic, and patient is less than 25 years old, definitely work up the patient.
2 minutes left.
Okay. Now, if you have those levels defined by Brewster as 1.5 times above the 97.5 percentile, and your EMG is myopathic or normal, then how would you proceed? This is one algorithm I would suggest. I would really focus on simple things like history, family history, especially for the residents. So not only ask about weakness, neuromuscular disease, but also ask about subtle clues to an underlying neuromuscular condition. For example, ask about cardiomyopathy in family members. Ask about rhabdomyolysis, malignant hyperthermia, and hypercikaemia, or high liver function tests that are without any obvious cause. If the family history is revealing and the patient is a female, definitely recommend screening for Duchenne carrier. If not, then you could either, depending on your available testing facilities, either go do a neuromuscular panel, myopathic panel, or do a muscle biopsy that can help guide you towards a targeted next generation sequencing. Obviously, if the patient does not have family history, you want to do a muscle biopsy to rule out a treatable condition, such as an inflammatory immune disorder. And eventually, if your workup is unrevealing after all of this, I would definitely recommend anesthesia precautions, assuming that you don't know what the underlying condition is, that there might be malignant hyperthermia susceptibility, and I would definitely recommend at least a baseline cardiac screen. So to summarize, workup in such cases should be individualized and tailored to each patient. Your main goals are looking for a treatable condition. You're trying to look for conditions that would require a more frequent cardiac screening, respiratory screening, and also identifying any susceptibility for malignant hyperthermia and guiding your genetic counseling, and thank you.
Thanks, Dr. Reem, for your excellent presentation and to be on time. Now, next speaker, it's my pleasure to introduce Dr. Ala Samkari. She is head of neuromuscular unit department of pathology and laboratory medicine at King Abdulaziz Medical City, Jeddah. She will present muscle and nerve pathology lab at King Khalid National Guard Hospital.
Thank you. Assalamu alaikum wa rahmatullah. First thing, I would like to thank the organizing committee, Dr. Aisha Sharif, Dr. Kopler, for giving me this opportunity to be here and present and share with you our experience in muscle and nerve biopsy lab at King Khalid National Guard Hospital. So as all of you knows by this time that muscle biopsy has an important role as a part of diagnostic process in assessment of patient with neuromuscular disease. Also, it play a role in detecting pathogenic genetic defect and contributing in genetic counseling and contribution to the development of new therapies. So we started the neuromuscular pathology as a separate unit within the anatomical pathology section in 2014. It was before that time just part of anatomical pathology lab. First, after I joined the department in 2011, after I did my fellowship in Canada in neuropathology for 2 years, so I joined the department 2011, and at that time, I started the proposal of initiating and creating the first neuromuscular pathology lab in the Western region. So the place was chosen, and the next important step was to identify the technician who is interested and have a special expertise in neuromuscular part. We were lucky to have Mr. Habib, who is between us and joined us in October 2014. By that time, the second part of neuromuscular unit was initiated by ordering the equipment, the special and special stains, immunohistochemical stains. We also created our separate neuromuscular DPP in 2015. And I will go over the procedure part. So all the orders now, it is online, being in our database in National Guard Hospital in best care. However, for outside referral cases, we have to have the order and to have it in hard copies, and it is very important to schedule these cases at least 1 day before and to notify us at least in the early morning if it is in-house cases. So also to have a diagnosis of muscle biopsy, we need to, as a pathologist, I need to know all the clinical information for in-house cases. It is all available in our database. However, we need to have a copy of medical reports, which include the important data, include the CPK level, EMG, nerve conduction test. If it is suspected to have a mitochondrial myopathy, we need to have it in advance so we can prepare also for the genetic studies. So it is usual. So how the collection of the specimen? In our center, it is done under general anesthesia in the general OR with the open biopsy procedure. The biopsy should be at least 1.5 by 0.5 centimeter, and if the clinician have a suspect of mitochondrial myopathy, we have a specific preparation also. Mr. Habib goes to the OR and take the muscle biopsy and immediately freeze a separate part of a biopsy that can be sent for genetic and these special studies. Common sites, we received the biopsy according to the involvement also, quadriceps muscle, gastrocnemius, biceps, not rare to be received. However, we have to choose a muscle who is not affected or the EMG was done on. So they have to choose the other side, of course. And to avoid a severely affected muscle, so we will not have a conformative pathology in which there is, for example, an end-stage muscle disease. So it has to be in the midway of the disease. So for the transportation, in-house specimen, it is should be immediately after taken from the patient, put in a piece of gauze, which is just moisturized with a saline. Don't immerse it in a saline or formalin or any other fixative, and to be immediately transported to our lab. In case if it is outside the specimen, we are receiving now from King Abdulaziz University Hospital, also from Armed Force Hospital from Mecca. And so this specimen in the container has to be put within a larger container, which is filled with ice. That's it. And to reach to the lab within an hour or maximum one and a half hour. So how do we proceed? We divide the specimen into the major one, which is the frozen material, which we do all the histochemical and immunohistochemical studies on. A small part will be fixed in glutaraldehyde to be sent for EM study. Now the EM in National Guard Hospital, it is centralized in Riyadh, and we have the pictures and images sent directly to me. The other part is in formalin fixed tissue. Of course, according to the amount of tissue, sometimes it is very small in tiny neonates in ICU. So we will divide or we will prioritize these divisions according to the case. Okay. That's why we have to have a special histotech. So there is a specific preparation for handling those muscle biopsy. It has to be put in a crock with a special media, and it has to be oriented in a longitudinal section. Then we will have, when we section those muscle, we will have the muscle fascicles on cross section. That's the whole idea. If we have put it in a longitudinal section or parallel sections of the fascicles, it will be useless for studying the histochemical stains and immunohistochemical stains. That's why it needs to be an expert person. However, in small, tiny specimens, again, if it is in needle biopsy or neonate, sometimes to orient these fibers, we have to see it under dissecting microscope to see the orientation of the fascicles. So we can orient it at that side. So this is, again, a higher magnification of how to put and to orient these muscle fibers. This is the second important step. It has to be immediately frozen. So we put it in isopentane for freezing, and this small container has to be put in liquid nitrogen, which is minus 180 degree. So in rapid freezing for 30 seconds to 1 minute, according to the size of the specimen. And then it will be left to cool a little bit in our cryostat, and then the sectioning will start. It has a special technique on sectioning those muscle specimens. Then the next, we can also collect, if we have many specimens coming in the same week, we can collect these sections and stain all the specimens together at the end of the week, as they are doing in larger centers, for example. So we will proceed with the special histochemical stains and immunohistochemical stains. So now we have the Ventana Benchmark XT, which we are doing. Last step is handling the specimen to me. So what I will have, the gross description, all the clinical information, and 2 trays, which usually contain the H&E, so section from the formalin fixed tissue, H&E with different levels of frozen material. All of these studies will be done on the frozen material. And we have all the special histochemical stain to study the oxidative enzymes, so NADH, COX, even combined COX and this DH, stands for studying the component of the muscle, so oil, red O, study the lipid, PAS, glycogen. And we used to have the ATPase to study the fiber type grouping. Now we replaced it by immunohistochemical stains, which is the myosin heavy chain slow for specifically to stain type 1 fibers, and the fast stain. And I will show you some examples. If the muscle needs immunohistochemical stains, we will proceed by ordering those I will proceed to order these immunohistochemical stains. So we have all the sarcoglycans, all the dystrophins, dysferlin, dysmin, and all myosin heavy chain, including neonatal, developmental, and we use spectrin as a positive control. So all the muscle fibers, I know these antibodies are working, merosin and emerin, too. So the first specimen processed in our house, in-house, received January 2015. So H&E and special stains. However, immunohistochemical stains done in Riyadh. A year after, we have a completed batch of immunohistochemical stains, just the EM, we are sending it to Riyadh. We did collected all the muscle biopsies, which was done just to have an idea how many from 2000 to 2017. You can see it was increased from 2008. It is variable from 6 to 27. Year 2014, you can see a spike there. I was covering National Guard Hospital Riyadh, so all the muscle biopsies were coming to me at that year. Regarding the age, most of the cases were children. Next, adult cases were 40%. Elderly were the least in the age group. Gender was male more common than female. So what are the muscle biopsy findings? Most of them were myopathic, so 41%. Next, non-specific, non-significant changes. We had also the neurogenic part, was or denervation part, 15%. type 2 fiber atrophy were next, and end-stage muscle disease were only 1%. So what are the myopathic changes? Most of them were non-specific myopathic changes. And next, inflammatory myopathy. We have 10 cases of muscular dystrophy and myopathy with abnormal mitochondria or muscle red ragged fibers. So I will show you just examples of a couple of cases which we have did in-house. So this is a case, H&E, so this is a section of a formalin-fixed tissue which shows variability in size and shape, fatty changes, and increase in connective tissue in between, which is confirmed by modified gomorrhic trichome. And this is a frozen material stained with H&E. And this is a dystrophin, which shows a nice mosaic pattern, patchy staining. So this was diagnosed as advanced myopathic changes consistent with muscular dystrophy. And I do put a comment and that the immunolabeling of dystrophin are in favor of Becker muscular dystrophy. So they have to put everything together, genetic and clinical information. This is another case which showed a mild variation in the muscle fiber size and shape. However, there was a nice ragged red fibers within the modified gomorrhic trichome. Also, there was missing or non-staining fibers in COX. We do the SDH COX combination, which is very beautiful. So the missed fibers who are not staining with the COX will be stained with SDH positive. So you will know this is a real defect in mitochondria. Also, we did an EM for this case. The quality was not too great, but there was an area of increased mitochondria and abnormal in shape and size. However, there was no specific crystalline inclusions or other features. So it was diagnosed as mitochondrial myopathy. This patient was actually following up in King Faisal Hospital, and I put this as a part of quality assurance thing. So it was reviewed by Dr. Kopler, and he agreed with the diagnosis. Another recent case, this case was received from Armed Force Hospital in Mecca. So it showed the variability in size and shape on H&E. However, there was some myopathic changes settled in the form of increased central nucleoli. This NADH showed the nice targetoid fibers. And this is to show you how it is very useful, the myosin heavy chain, slow and fast, to see the type 1 group, also the type 2 group. So there was two type grouping. Also to confirm that the atrophy are of the both types, so type 2 and type 1. So this is to confirm that it is a denervation atrophy. However, this case was suspected to have inflammatory myositis. So I always discuss the case with the sending physician. And also this case was seen by another pathologist, so I sent it over to have to confirm the diagnosis. This done as a quality assurance things and in cases where the clinical and pathological picture didn't match. This is another case or nice case of inflammatory myositis or inflammatory myopathy. Most of the cases of inflammatory myopathy doesn't need the special stains, immunohistochemical stains. So in these cases, I will not proceed with the immunohistochemical stains in case we have an answer on the H&E stain slides.
2 minutes.
So it is inflammatory myopathy, and there was secondary steroid also changes. This is just to show you the format of the report. So it will include the collecting date, receiving date, of course, on top the information of the patient. I learned to call it myopathy with ragged red fibers rather than directly mitochondrial myopathy. And I always put up a comment regarding the microscopy, if there is any specific changes or the case discussed with the clinician. Of course, the gross description, all the information of the microscopy, all the detailed of the special stains, immunohistochemical stains, even the electron microscopy are in the report for you to share. We have also nerve biopsies, which we receive fresh. However, the procedure much easier and shorter than the muscle biopsy. Sural nerve is being the most unusual biopsy site. It has also to be taken and handling freshly and it has a special maneuver in handling it to avoid the crush artifact, which is a major artifact we see in the nerve biopsy. So again, we have to be immediately taking the biopsy to the lab. Again, it has to be not immersed in any solutions or fixative in just moisturized gauze. And
Could you conclude,
also
please?
we collected.
Time is finished.
Okay. We saw there was 30 nerve biopsies over last 18 years. Only 2 of them showed specific changes. 2 of them were non-diagnostic, so they missed it as, and they were fibrous tissue or blood vessels. 27 of these 30 nerves were accompanied by muscle biopsy. So some were not. So what is the current status? Our lab now is fully structured, fully equipped. All the special histochemical stains and immunohistochemical panel are completed. We are, thanks God, we are receiving and reporting from outside hospitals over the couple of years, except the EM we are sending to Riyadh. More antibodies requested, and a new cryostat machine is coming. Also, we are in process of training another senior technician in case Mr. Habib is on vacation, so we will not stop the service. We are also receiving now the specimens from Riyadh because our stains are much better than them. So this is another great things happening to us. We are validating the stains, discussing the cases, and we have also monthly discussion among the neurologists, and we will go back to that. We stopped it for a while. So I hope really that this lab will continue to serve all the patients in the region. We want to receive more cases from outside hospitals. It is not difficult, just we will follow the right procedure. I hope to have a bedside biopsy rather than general anesthesia, so we will have more patients, avoiding the complication of putting the patients in OR list, and if possible, needle biopsy. We will have our neuroscience center and trauma center in the coming 5 years, so I hope also to proceed with the procedure room inside our lab. Thank you very much.
Thanks, Dr. Ala, for sharing this data and your experience in King Khalid National Guard Hospital. Now we're going to move to the next speaker, Dr. Fatima Al-Garni. She is adult consultant neurologist and neuromuscular disorders and electrodiagnostic medicine at King Abdullah bin Abdulaziz Hospital at Riyadh. Her talk will be on acute neuromuscular disorder clinical application. So please go on.
Good morning, everybody. I would like really to thank Dr. Koppler, Dr. Aisha Sharif for putting all together event. Thank you all for sticking around and staying for till the last day. I'm here to share you some clinical tips and approach to how we manage acute neuromuscular disorders. It's good always to get together and raise awareness about how to manage disease as a physician. But I got touched when I preparing this presentation. I got touched by this video. She's a patient, and I hope it's gonna work. How can I make it work? Okay. Listen carefully to this patient, and
this is the video that I promised I would make, showing you the tempo to count for the single breath test. My neurologist taught me this test so that I could stay safe and feel safe leaving the hospital after my diagnosis. My breathing is very compromised with my MG, and my normal is usually between 40 and 45. And today, well, let's see what my count is. You take in a pretty good deep breath, and you count as far as you can in one single breath without taking another. So here it goes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 20, oh, 28. Ooh, 28. Good thing that I have treatment tomorrow. 28. I didn't realize that I was down to 28 today. So there you go. The single breath test really can tell you that you're having a little bit of difficulty.
I will stop here. She was taught by her neurologist about how to do single breath tests, which you usually do in the clinic or an emergency situation. And we know that she has ptosis and apparently, and she was diagnosed with myasthenia gravis, and teaching patients and raising awareness with those who's really diagnosed with certain neuromuscular diseases, it can be life-saving. And she just realized that she has dropped in her single breath test and she has this difficulty breathing. And I will go to the presentation with starting with a certain definition about acute neuromuscular disorders and neuromuscular emergencies, giving you practical approach and whether an emergency in ICU setting and focusing with the most important aspect in case of acute neuromuscular emergencies, which is primary neuromuscular failure, and how we approach and how we, from clinical perspective, diagnose them early on. And if we have time, we can just discuss a specific disease, the treatment, and I would share you, conclude you with an interesting case that I happened to manage. When we defined the acute neuromuscular paralysis, there was a bit conflicting and a definition. However, any rapid progressive muscle weakness less than 4 weeks, that's considered emergencies, especially if there is bulbar and respiratory. You have to deal with them as an emergency situation and start, it gives you full attention about this kind of diseases. However, we know that sometimes neuromuscular weakness can build up over minutes and even hours, example like periodic paralysis. So you need to be like open-minded to every single acute weakness in the emergency room. And may or may not have bulbar respiratory, but it's very essential to diagnose and focus and specifically looking for the bulbar or respiratory involvement. It's because it carries high mortality if there is bulbar involvement, respiratory, or even autonomic. So even autonomic dysfunction has to be recognized and immediately when you assess this patient. Why it's very necessary? Because it was found that diagnosing and reaching a final diagnosis with this kind of patient, they carry more prognostic value, they have better prognosis, easy to manage, which is logic, to be honest. Globally, you know, the most common GBS and myasthenia gravis or myasthenic crisis, followed by myasthenic crisis. However, there are a host of them which you need really to keep open-minded about them. When we come to approach acute neuromuscular weakness, if you have flaccid paralysis or quadriparesis or paraparesis, you start thinking anatomically. And this is really what we are doing when we examine and seeing the patient. Anatomical classifications, and which started from anterior dorsal disease, passing through peripheral nerves, and ending up with neuromuscular junction and muscle. Each single defect in those areas can present with acute neuromuscular disorders, as you will see. Very important to complement your clinical assessment with a neurophysiological assessment. And I will not discuss today the neurophysiological assessment because we have workshop. Perhaps Dr. Sajjad will discuss it further in his talk. So just keep just keep this motor unit pathway always in your mind when you're assessing the patient an emergency department. I hope this slide is clear. If we have symmetrical weakness, when we start seeing patient with acute weakness and an emergency room, for example, we start thinking immediately in this way as a neuromuscular specialist, and I hope every general neurologist start thinking that way. If you have symmetrical weakness, the first thing you would know, is this pure motor? This is symmetrical or asymmetrical. This is pure motor. Patient has no sensory. Then this is your direction of. If it has pure motor, then definitely the localization most likely will be neuromuscular junction or muscle disease or myopathy. And you start thinking in that way. If you have a predominant, yet there is mild sensory, then this is most likely polyneuropathy with the predominant motor. Example, classic GBS form, where they present with mild sensory or motor predominant presentation, relapsing form of CIDP or porphyria. If you have significant sensory symptoms along with this acute paralysis, then the localization should not be exceeding, should be in the setup of polyradiculopathy, polyneuropathy. Then here we go. The acute polyneuropathy will be your most likely. You're not thinking in the either extreme of motor unit, whether this is muscle, neuromuscular junction, or anterior horn cell disease. So GBS usually is the commonest, and vasculitis and toxic. Keep open-minded about the other possibility like toxic neuropathy, vasculitis and neuropathy, where they present sometimes as GBS-like sarcoidosis. We have an interesting case report there that about sarcoidosis and as well and neuroprocillosis. Keep open-minded. However, the approach will be very clear if you have significant sensory. Of course, rare syndrome, like Dr. Kurdi talked about, neuromyopathic, that they present with this kind of altogether. However, commonly, it's easier to differentiate. Rare neuromyopathic syndrome will present in acute setting. Asymmetrical weakness, by far, is the anterior horn cell disease. If you have pure motor, asymmetrical weakness, always think and poliomyelitis-like, anterior horn cell disease. If they have respiratory failure, ALS is your differential, and it's usually pure motor, it's symmetrical. I will not dig about history because most of neurologists or neurology residents, we are trained very well in how to take. However, the home message when you start evaluating patient with acute neuromuscular is tips that I want even to keep it in your mind. Not only the time and the tempo and the progression and involvement of respiratory or bulbar or sensory. Dig more if this is recurrent. Is this your first attack? Because recurrence always give you hint whether this is kind of a neuromuscular junction, periodic paralysis would give you, it will limit even more your differential. Remitting, relapsing CIDP, etc. Dig more in dyspnea and shortness of breath, because early it will be subtle. Even patient cannot tell you, cannot come and volunteer and complain. Ask him how many pillows you need before you sleep. Has that been changed recently? Is there like an orthopnea, suggestive? Of course, fatigability. Always elicit about any triggers. Do not forget the triggers. And I know most of you ask about infection, vaccine, surgery, etc. However, another important trigger, new medications, especially in terms of myasthenia and myasthenic crisis. Most of patients, they will put they got infection, they will put blindly in any kind of antibiotic. This is, for example, quinolones, aminoglycoside, which will bring the myasthenic symptoms clear, or sometimes it will unmask the presentation of myasthenia. So always keep and ask the patient any recent medication has been received before this happened. Of course, other systemic disease is important when you assess patient in acute setting. Here we go. If you have patient history, have pure motor symptoms or mixed motor and sensory, think about approaching in motor unit pathways. So if you have muscle, and as you see muscle and neuromuscular junction, you have pure motor. Usually we have normal reflexes and normal sensory. So the examination is at the extent actually of your history, if you're moving up. If you have mixed motor and sensory, then you will have reduced It will complement the history, reduced reflexes and sensory involvement. If you have asymmetrical pure motor, will be anterior horn cell disease, and we'll come to the etiology, the commonest etiology. In acute, again, I remind you that this is acute neuromuscular setting. So always keep this in your mind. Most of them in acute neuromuscular, they might possibly have respiratory involvement. However, the commonest by far is neuromuscular junctions and polyneuropathy, like GBS, acute polyneuropathy. And involvement of certain things like bulbar, ocular usually they would commonly they will come with neuromuscular junction. Less likely will come with GBS when in an acute neuromuscular setting. So always keep this in your mind. And I will not dig much about examination. However, the general examination that always will look to the patient as a whole. We tend to go to the emergency room with a neurology mind and jump immediately to examine neurological exam and do and just go home. Please focus on patient as a whole. Look to the patient how he is sitting. Is he comfortable? Is he restless? Is he sweating? Look to his vital signs. Is there like any bradycardia, tachycardia, hypertension? Is there like any kind of alter in hypertension or his pulse thing? Because this might tells you, and we'll come to the section of how we assess respiratory muscle weakness. Then assess his respiratory. Look the way he talked to you. Is he talking in a staccato speech, we call it? Is he stopping each time he cannot complete his sentences? Keep this in your mind when you assess patient. Keep open-minded for other involvement like skin rashes, vasculitis and neuropathy, dermatomyositis changes. If you have Lyme disease, if you are in that area that Lyme present, always keep your mind open for systematic, and skin usually is very important. And then you will go to neurological assessment, where you start always. I ask our residents to avoid things, always start from up and down. Start from assessing patient from ocular, bulbar. Is there like ptosis, drop in ptosis, restriction eye movement? Because this will tell you a clue and will eliminate bunch of acute neuromuscular etiology. So if you have ophthalmoplegia, ptosis, then you're with a pure motor, then this most likely neuromuscular junction, and the etiology usually is myasthenia gravis. If you have this ptosis and ophthalmoplegia, which can be sometimes seen in GBS, where the patient has mixed motor and sensory symptoms. So always keep this in your mind. So if you have this, and I know neuromuscular is sometimes is really tedious things to remember the entire etiology of all neuromuscular disorders. However, in acute setting, we have limited differential. Be open-minded about all of them, because you might see any of them. And trust me, I saw most of the rare cases that I cannot even imagine that they do exist. Example of acute motor neuron disease, acute internal disease, poliomyelitis-like, and perhaps you heard about this endemic kind of poliomyelitis-like. Keep an open way. They present with a symmetrical kind of weakness, pure motor, no sensory, and diminished reflexes. Keep always thinking about that. Of course, the ALS, where they present acutely with respiratory, might be also with your differential. West Nile virus and endemic areas is a very important differential. Peripheral neuropathy by far is the commonest, is GBS, the classic form of GBS, as most of you know, and I'm sure you heard about them in lectures and their variant as well. CIDP relapses. Many of neurologists think that CIDP commonly present with remitting relapsing, and they would think they will manage them as GBS, which might be okay in the acute setting. However, keep always CIDP, and I've seen that they will be discharged and managed, and then they will go home. While the truth is they have to be managed as CIDP based on history and neurophysiology. CMV, if you have patient with immunocompromised patient, CMV really required to, because if you do a polyneuropathy and you do the CSF, you'll find biliocytosis. this is red flags that this is something else going on. Like if you have polycytosis and then consider infectious, HIV example, CMV, polyradiculopathy, because it's fatal and treatable condition at the same time. Porphyria, keep open-minded and ask about the history suggestive like GI or skin rash, etc., or say neuropsychiatric manifestation. Neuromuscular by far junction is the myasthenia gravis, followed by botulism. Muscle disease is the commonest with acute neuroparalysis is periodic paralysis, and it's far beyond this talk. However, we need to keep this in mind whenever we ask to manage patient in acute setting. If you are in an
Sorry.
no, I think you got my time from the other presentation. Essential investigation. How we investigate them? Definitely after clinical assessment, CK and nerve conduction and EMG is essential part. If you are lucky and have this, you have, because this is will limit and tell you where are you going and where are you heading. And then depending on the etiology that you reach or you think, you will manage your, and because of time, I'll not discuss further investigation. But you know that most of things you will do CSF, electrolytes, potassium, magnesium, serology, for example, for myasthenia gravis and for GBS. I'll not discuss AMG because of time. The important message about this syndrome, primary acute neuromuscular failure, how we assess them, because early recognition and determination of the cause is very important and essential. The outcome is usually poor when you are not diagnosing. So, and rarely it's a presenting feature. How we assess them in emergency or as we saw in the lady, you have to ask a patient to count loudly from 1 to up in single breath test. It's not only for myasthenia, by the way. Any acute paralysis, ask the patient. Listen to his speech.
It will be 2 minutes, huh?
Sorry?
You'll have 2 minutes more.
2 minutes?
Yeah. Please try to
طيب.
wrap up.
And then you have paradoxical breathing type. We don't examine this usually, but I urge you to examine and start thinking about how we examine paradoxical breath typing. By looking at the patient, you might expose his abdomen and chest and putting, and if you don't see this paradoxical breathing, usually we take in, when we inspiration, we inflate both abdomen and chest. However, what happened because of diaphragmatic weakness, there will be inward abdominal. It will not be like a bulge. There will be like inhale and inward movement. Put your hand on chest and abdomen and ask the patient to take deep breath. If they inhale together, if they exhale together, if they elevate it together, then this is normal breathing. If the abdomen just go deep or get inward, then this is paradoxical. Very reliable marker for diaphragmatic weakness and very essential in managing patient with acute neuromuscular disorders and respiratory failure.
Time is off
respiratory failure. The common
Hello?
do not, yes?
It's time off now.
Can have 2 minutes more? I'll come to the conclude. Vital capacity, ask the respiratory to assess vital capacity, max expiratory pressure, and MEP. This is very important to have spirometry. Vital capacity is essential because hypoxemia and hypercapnia and regular ABG will not exclude respiratory involvement at all. So your assessment is after clinically assessing him for a periodic pattern. You have paradoxical breathing pattern. You have to do spirometry, no matter where the patient in emergency or in the floor. I will just, because there are, why it's important? Because you have to fight for patients. Non-invasive ventilation, whether he required intubation or tracheostomy, always, sometimes it's your decision. It's not only, we leave usually the intensivist for the bigger decision, but however, for early respiratory involvement, if the patient in myasthenic crisis, you have to put him in non-invasive ventilator and positive pressure, non-invasive ventilation, and ask him to be monitored in high dependency or even in ICU before. This will give a very good prognosis for the patient and prevent even intubation as supported by evidence. I think I'm running out of time, and then I will just ask you, with the elective intubation, we know the emergency intubation, you have to have hypoxemia, hypercapnia, which is not always the case in early respiratory involvement. When to have elective, when you fight for your patient to have elective intubation, patient cannot take the breath in one single breath. It's less than, cannot count even to 20 in one single breath. Like this lady was really borderline. For if the patient has vital capacity less than 20, 30, 40 rules. Remember that and ask your respiratory therapist if this is decline, it's better to have patient electively intubated, do not wait for emergency intubation to have better prognosis. I will skip disease-specific management because we not only have many
We already
many
finished the time now.
many discussion about GBS and myasthenia gravis. I wish I had the time. I thought I have it, but I think I'm not. Can I share just the case, the last case? No. طيب.
2 minutes later.
I will conclude by please consider an acute neuromuscular diseases. It's a neurological emergency, required prompt diagnosis and recognition. Those who have recognized and reached the etiology, they will have much better prognosis. Paradoxical breathing pattern and single breath test, please do it as a clinician, as a neurology, and examine your patient, whether in an emergency, in a floor. Look always for the subtle signs. It will tell you a lot and about which patient that you have emergency intervention. For those who has unexplained respiratory failure and there is no diagnosis, always consider ALS, and there is like an evidence for that. And of course, disease-specific management like a rapid plasma exchange or IVIG and immune-mediated like has been found to be very effective. And thank you very much.
I have the pleasure to introduce the second speakers, Dr. Sajid Ali. Dr. Sajid Ali is an adult consultant neurologist. He is a clinical neurophysiologist, a specialist, and he works right now in King Fahd Medical City. Welcome, Dr. Sajid. Please start.
Good afternoon and assalamu alaikum wa rahmatullah, everybody. Thanks for the committee for inviting me to talk today, Dr. Aisha and Dr. Kapler. And thank you all for sticking until the last bits of the conference. Now, my topic is going to talk about the neuromuscular electrodiagnostic evaluation. I think it's more about looking at basic technique, looking at the technical pitfalls, and having some view over how sensitive and specific these tests are. Dr. Fatma put up this diagram, and I've just put another version of it. And I think whenever residents are rotating with me, I really emphasize on this diagram to make this as a mind map of your approach to any neuromuscular disorder, whether it's clinical examination or its electrodiagnostic approach. Of the routine stuff, I will be talking about disorders, electrodiagnostic evaluation of the neuromuscular disorder, and we'll talk about repetitive nerve stimulation and single fiber EMG. And so approaching electrodiagnostically the neuromuscular junction, this test can help us to look at the distribution of the disease in terms of myasthenia gravis or any other neuromuscular disorder. It does give us some insight about the pathology involving if it's at the level of the presynaptic junction or the postsynaptic membrane, and to some extent it does give some information about if the disorder is acquired or inherited. Now, these are intracellular recordings, schematic of what happens at the end plate region. And you can see that there is a delay when we give up electrical pulse for the acetylcholine to sort of get to the so there is a bit of a delay for the acetylcholine to go and sort of diffuse across the cleft and initiate an end plate potential. And when it reaches the threshold, we get an action potential. In this diagram, what we have, it's showing is that the action potential has been inhibited so that you can see the end plate potential to its fullest. And we see that the end plate potential goes many times above the threshold. And we do see on the second and the consecutive third stimulation that there is a drop of this end plate potential. And this happens in the normal neuromuscular junction. And however, obviously, because it's way above the threshold, and that constitutes our safety factor as the main fundamental factor that we use for doing repetitive nerve stimulation. What happens in myasthenia, you can see over here, the first impulse which initiate, it's a very low sort of amplitude. The EPP or the end plate potential doesn't go that high. It initiates an action potential. And the second one barely reaches the threshold, and you can see the drop in the action potential. And the third one does not reach up to the threshold, and you see no action potential, so it works as all or none principle. When we put in the action potential themselves as if they were initiated, we see in the normal neuromuscular junction, we have 1, 2, 3, all sort of big potentials overlapping synchronously, and there's no sort of decrement or drop over there. Whereas what we see in the myasthenia gravis is that there is variability of this action potential at its arriving time at the electrode, and then the second one arrives a bit later, and this constitutes the neuromuscular jitter, which we record with single fiber EMG. We again see that the one which is below threshold does not initiate any action potential. Now, if we look at the neuromuscular junction in a disease form and try to explain the decrement we see in myasthenia, we take these small bars at individual end plates in the junction, and obviously there is a spectrum of disease. Some end plates are quite severely involved, some are less involved, and some are healthy. We see that this end plate only could generate one potential, and after that it got blocked, and this could generate 2 and then 3 and up to here over 4. And over here we could see that these end plates generated the potentials all along. All of these end plate activity or end plate potentials are summated under the electrode on the surface that we are recording in RNS. And this constitutes the CMAP, which is the showing the summation of these end plate potentials. And here we can clearly see that there is a drop in the CMAP, and it goes down, and subsequently there is a bit of repair where the extra sources of acetylcholine are mobilized, and some degree of facilitation also occurs. Over here we see that there are a couple of end plates which sort of become a bit, after continuous stimulus for a while, go through some degree of intratetanic facilitation, and we see this sort of a repair. And this is what one of the things which is like a quality marker of your RNS study is that you want to see this saddle shape phenomena, or what you call the U shape, where you see the decrement and some degree of repair following the normal sort of physiology as it is affected in the myasthenia gravis. And this essentially shows you the summary of the whole of the RNS business. In the first example, we see the normal stimulation, the first, and we compare that with the fourth or the fifth, and we don't see any decrement. And after that, this is slow 3 Hz stimulation. We record 10 pulses. One could argue and record only 4 or 5, which is enough, but the reason we record 10 is that we want to see that repair phenomena occurring later on. After a brief exercise or activation of 10 seconds, we try to see if there's any repair, and then we see 1 minute after that exercise. What happens in myasthenia is that you see the decrement over the 4th or 5th response, and then gradually you see the repair coming in. And after a bit of 10-second exercise, you see the decrement. So if you have that, then definitely you're dealing with some movement or pitfalls. What happens in LEMS is a presynaptic. You do have a very small response right at the baseline, and when you do 3 Hz slow stimulation, you see a bit of decrement there as well and bit of repair. But when you do just a 10-second exercise, which is equivalent to fast stimulation, you get a incremental response, and after a minute, again, you see the decrement response. Now, it's just not the degree of decrement that you are able to record in RNS. If you look at your baseline CMAP potential, and if you see if the potential is low, that just tells you that they are very less end plate functioning. And when you do an incremental exercise, then you see that the repair in the decrement, but also the repair in the CMAP, which shows that there is possible end plates which can be repaired, and that will tell you clinically that these patients may benefit from mastodon. And if you see that there is no repair in the CMAP amplitude itself, then it means that giving mastodon in such patients may not be that beneficial. Now, why to stick with 10-second exercise? This shows very clearly that 5 to 10 seconds is the most that you get, and after that there is a drop. So any more prolonged exercise is not that much useful to see the increment, especially in LEMS. Going on to the first pitfall, utterly important is that the stimulating muscle is immobilized and you have an isometric electric position, because what happens over here is you can see that this is recording from the median nerve where the muscle was moved from a position of adduction to abduction, and each of the, we can see that there is smooth drop in the CMAP. However, the concurrent area that was recorded was concordant and did not show that decrement. So this is a purely technical sort of decrement which does not represent true decrement. So it is very essential that your hand or your muscle which you're testing is immobilized to the best possible way. If you stimulate submaximally, you may get a very variable response, and the same stimulus when given supramaximally, there is almost no decrement. So it's important that you are supramax, and you could just take a supramax on your CMAP amplitude in your motor conduction study, and then mark that for that particular muscle before you come to the RNS program. Temperature must be controlled because cold muscles would sort of mask the decrement. Usually, acetylcholine inhibitors should be ideally held before the study. If you ask the patient to skip the dose night before, have the test done in the morning, and then they can have their first morning dose after the test. Some institutes, although, do not want to do this if the patient is a bit critical with the risk of sort of exacerbating the underlying condition. But I think that probably depends from the patient's condition and how much stopping 1 or 2 doses would affect. When I speak to Eric Starberg, and he always says this, that recording RNS from a distal muscle is a waste of time. And this shows over here, nerve selection is very important. In children or even in some adults, it's not a very comfortable test to do. So if you really have the limited option of which muscles you're going to look for, then it's better to stick with proximal muscles. You can see over here that the ADM only showed borderline decrement, whereas it was quite significant in the trapezius. So the protocol for RNS is 3 Hz stimulation with 10 stimuli, ensuring that the muscle is immobilized, giving a maximum, supramaximum stimulus, and testing at a brief 10-second exercise, and after that just a minute. I usually would not prefer to do further post-exercise exhaustion, because that does not give me any further clinical information. However, it is nice to see those graphs going down if you really have that time in your clinic. Going on to the second modality, single fiber EMG. When we're recording the motor unit action potential, what we do is that we introduce electrode which has the ability to record 2 muscle fiber action potentials simultaneously, and that constitutes our single fiber EMG. And now this is showing the conventional single fiber electrode with the uptake area on the side, which is around 25 microns, with the average diameter of a muscle fiber being 50 microns. So easily you can record a single fiber potential. but because these are reusable needles, they need autoclaving, and at least where I trained in the UK, nobody is using them anymore because of the risk of disease and prion disease infections. So what we've come up with is now the facial concentric needle. So a conventional single fiber would have a recording area of 1 muscle fiber or less, whereas in a conventional concentric facial needle with an area of 0.19 to 0.2, you could record up to 3 muscle fiber potentials. And what you record is the time it takes from one fiber potential to reach to the needle as compared to the other one that reaches over there. And this basically, you can see over here that you trigger one of the responses, whereas you see the time the second one takes to get to the needle, and you see the variability in this time, which constitutes the jitter. Over here, you can see the variability, and the jitter is abnormal, whereas over here, it becomes a bit more abnormal, and you see at times there is no pulse or potential recorded, which constitutes neuromuscular blocking. 2 technical ways of recording this is that you start a stopwatch at the uprise time of the first wave, and we compare it at a stopwatch at the uprise time of the second one. So this is like looking the rise time, or you can do is that you can look at the peak and calculate the peak time it takes from 1 to the second, and then the first to the third and the fourth, and this gives you the jitter. And what you're calculating is the interpotential.
2 minutes, eh? 2 minutes.
I thought I had 20 minutes anyways.
It's 20 minutes.
Interpotential intervals, and you take the average of these intervals and you calculate the mean consecutive difference. Some pitfalls over here, you can see in the diagram that there is a loss of these 3 sort of potentials, which you see concomitant blocking in over here and over here. And what happens is that if these potentials are recorded from a branch and there is a delay in the neuromuscular transmission at this level, all the consecutive branches will all block together, and it looks like blocking, but not single, but multiple spikes over there. Another thing to recognize is the velocity recovery function, especially in stimulated single fiber, where if you switch over the stimulation frequency, you see that the shift of the potentials towards the left side, and you might want to exclude these because this is more of technical, as they may sort of contaminate your jitter recording. Importantly, again in stimulation, is that you use suprathreshold stimulus. You can see the variability of liminal or insufficient stimulation, showing a variable jitter which corrects with suprathreshold stimulation. Axon reflex is another thing. If you are stimulating a fiber, if you stimulate higher, you may activate it directly, and what it shows over here is the same pulse having 2 different latency at different intensities. So this is important to realize that if you increase the intensity, it will have an axon reflex where it will stimulate this next fiber, and you have a bit of a delay in that. So you need to be aware of this. Now routine concentric needle recording, we have the normative data. This was multi-center trial with Eric Stahlberg, Donald Sanders, and
We have 1 minute
other,
more, eh?
and other people, which sort of constituted the normative data, which is over there. I'm not going to go into that. Just last few slides. I'm being hurried. I think I had 20 minutes to my time, so if somebody else has taken my time, I apologize for that. Electrodiagnostic approach to jitter analysis is in some labs which are doing single fiber, they would first do a single fiber, and if that is normal, they would just stop there. Because it's never seen in that with a normal jitter, you would have an abnormal RNS test. However, if you have an abnormal jitter, you still want to do the RNS because you want to look at the decrement, and you see you can follow it for follow-up. And this is from Stahlberg again, around 500 patients showing decrement of around 5%. And this is, I think, important. I had this discussion with Dr. Ahmad Abu Zinada yesterday, that why we kept 10%, why not 5%? Ideally, a muscle should not have decrement. So this would increase the yield if you lower your cutoff to 5% decrement. Briefly showing you the specificity, sensitivities of this test. In ocular myasthenia, single fiber up to 85%. in moderate to generalized quite significantly sensitive as compared to just a hand muscle, which is just 4% decrement, however, in which increases in more generalized or severe forms. From Donald Sanders, more than 500 patients showing
Dr. Sajid, time
sensitivity.
up.
Okay. Sensitivity of the up to 99% of single fiber in generalized and 97% in ocular, and you can see the RN is 76 and 48%. And I'll like to thank Eric Stahlberg for allowing me to use his slides. I've learned a lot from him and has been my mentor. And I think I finished in almost 12 minutes. Thank you.
Thank you, Dr. Sajid. We're now, the last session is actually with Dr. Ashraf Dalul. I hope I pronounced the name okay. He is an associated professor in genomic medicine, King Abdulaziz University, Jeddah, Saudi Arabia. Welcome, Dr. Ashraf. Please start.
Assalamu alaikum. I would like to begin by thanking the organizers for giving me this opportunity to give this talk to such a distinguished audience. I'm representing what we call ROIA, which is Specialized Medical Diagnostic Laboratories at King Abdulaziz University, which is a unique vision by amalgamation of different centers at the university to unify their facilities and their expertise to offer professional genetic diagnostics to the society. Just a quick introduction. Probably I'm very late with this introduction now. Neuromuscular disorders. To me, I don't know much about neuromuscular disorders. I'm going to talk about the genetic element of it. And it's fascinating to see that there are so many diseases. One census says that there are over 900 diseases, of which 500 genes are responsible for these diseases. So there's a challenge when you offer genetic diagnostics for neuromuscular disorders, what kind of test to offer. And this is where the talk will be heading to suggest one test for many of these diseases. And this test is based on next generation sequencing. You probably heard about earlier in the sessions. And because of the current advances in it, allows a cost-effective way of screening the patients pretty quickly. Within 8 weeks, you'll get a result back, a report, where you can, in 50 to 70% of the cases, have a diagnosis that you suspected, have a prognosis, or maybe give you a diagnosis completely different from what you initially thought. I mean, why do we get samples for genetic testing? Basically to establish a diagnosis, clarify the prognosis, assist with the treatment and management, and clarify risk of disease for family members. And this is a very important point. I mean, because initially the clinician suspect a genetic element when there is multiple cases in the same family. There is a recurrence in the family, or there's multiple generations. And this inheritance can be autosomal recessive, where you can see the disease skipping a generation, or autosomal dominant, where you can see the disease in the father and the son, and the father and the mother and the daughter, and in the subsequent generations. And there's the X-linked element also, like the famous one is DMD. And so this is where genetic testing can help in all of these areas. However, from our experience in Roya for the past year, there's a major barrier to this, which is the financial cost. The financial cost, because not all insurance companies cover it, so the patient have to sponsor the test themselves. This is where we worked really hard to bring the cost down so that it becomes in an affordable category. The other barrier to offering genetic testing for a wide section of the patients is what to do with the genetic information, because the genetic information, the inheritance pattern, can affect the family in a social context. You're probably aware of that more than I do. The other thing I want to highlight is when we report back a positive result on the genetic report, indicates that the disease-causing mutation was identified in the individual. So we're pretty sure that the gene has been identified, and the mutation in that gene is responsible for the disease. Unfortunately, the human genome have so many polymorphisms, have so many changes in the sequence, many of which can be misleading. So there's a lot of care has to be taken to arrive to the conclusion that this particular sequence change is pathogenic. This is why the 8 months, actually, the 8 weeks period required for reporting back to the patient, because the actual test takes about 3 weeks in the lab, but the rest is for analysis, validation, quality control, and going back, discussing the finding with the clinicians sometimes. All that takes some time, but when the report is issued, we're pretty sure of it. A negative result also is interesting to highlight. A negative result can be two kinds. A negative, true negative, where we know the mutation, we know the genetic cause in a family member, then we screen another, the suspected case, and he or she is negative for it, then he or she is truly negative for that genetic mutation. However, with the NGS, with the next generation sequencing and exome sequencing, we often encounter cases where the patient, the person we are testing is exhibiting the disease or the syndrome or the disorder. But when we test him or her, we don't find a pathogenic mutation. That could be due to the disease, the gene is not known yet. The gene itself, the sensitivity of the test, the mutation is beyond the sensitivity of the test because we rely on exome sequencing, and exome sequencing have its limitations. Just to put it in context, I mean, the genetic testing approach is available right now. We have the karyotyping, simple chromosome analysis, where you count the chromosomes and see the structural abnormalities and report them. We have the FISH analysis, fluorescent in situ hybridization. We have the chromosomal microarrays. This is a very useful tool also to find the deletions, amplifications that are too small to find by karyotyping. And we have the one we're focusing on in this talk is sequencing. And sequencing can be done at a single gene level, or it can be done at a multi-gene level using next generation. And the multi-gene level, now it's called exome sequencing. Exome sequencing is an extremely efficient way to screen the entire genome, the coding genome, where the parts of the genome responsible for producing proteins is very useful tool, and it's indicated, in my opinion, should be indicated as a first line of investigation when there's a familial condition, there's a family inheritance, there's multiple generations, multiple affected members of the family. And you can see here, there's a very good case where you can suspect a genetic element where multiple members affected and high degree of consanguinity and inbreeding. So a family like this is an extremely good candidate for exome sequencing because you will find the gene. Unfortunately, it's not the magic solution that everybody thinks of. There are some cases we don't find a mutation. There are reports that turn out to be negative. Negative because we haven't seen a mutation that is convincing us that it's responsible for the disease. So these are because, I mean, there are percentages around like 50% of the cases can have a positive finding. In our hands, we're around 60 to 70%. So we're doing pretty well with that. There are certain limitations. I mean, why we are missing out on the other 50%? There are limitations on the test itself. There are limitations on the knowledge about the variants we identify, because we identify the variants, but we cannot correlate it with a phenotype. So we cannot say this gene C19 or 5, which has no information on its function, a mutation in it is causing this disease. So this is the problem. We rely on the phenotype. So quick definitions before I go more into the talk. you're probably familiar with targeted gene panels, clinical exome, whole exome, and whole genome. And often the clinicians request whole exome. But is it always necessary? Probably not. There's a clinical exome, is comprehensive but targeted sequence of regions within the exome known to be associated with clinical phenotype. So instead of sequencing 14,000 genes, 7,000 of them have no phenotype. We can focus on the 7,000 genes and come up with a quicker, cheaper way to do this. It's probably, I will expand on the clinical exome. Whole exome is doing the clinical exome, but we will have to include the 7,000 genes that we don't know anything about. Targeted gene panels, some people say, yes, we can use a gene panel for Charcot-Marie-Tooth. But the number of genes involved in Charcot-Marie-Tooth is quite large. So the cost and speed and turnaround time will be the same as doing the clinical exome. So the advantage of the gene panel, they sometimes are more sensitive to detect the mutation. Sometimes are more sensitive, and depending on the supplier. But the clinical exome is the best, in my opinion, the best solution to start with. Whole genome is very, very nice, but it's 3 times the cost of a clinical exome. You end up with a huge amount of data for each patient, and it takes longer to analyze. And again, if nobody else is paying for the patient has to pay themselves. The cost of the whole genome is around 10,000 to 12,000 riyals. It's probably too much, because you can, in 80% of the cases, get the same values or the same data from clinical exomes. So this is actually the decision of the clinician, the specialist who is treating the patient, which one to go for. But in my opinion, from working in the lab for the past few years, the clinical exome is the best solution. Skip that. I'll just highlight 2 of the available clinical exomes right now. We started with TrueSight 1 sequencing panel. It's 4,800 genes. It's quite cost effective, and you can run as small as 3 samples per run, which means your turnaround time will be quick, because you're not waiting for the number of samples to accumulate before you can start your own machine, because the cost of NGS is in the machine. How many samples you put in the sequencing machine determine how much your sample is costing at the end. Another one we are moving into, which is expanded. Instead of 4,800 genes, there are 7,000 genes now, and that is also expanding the potential of the test to identify a positive mutation. The genes, the 7,000 genes, were selected by Illumina from reputable sources you probably use already: OMIM, ClinVar, HGNC, and HGMD. All the genes and the mutations in these databases have been selected, and the genes in those databases are represented in the targeted clinical exome panels. If I have some time, the exome itself works by you have your genes with exons and introns. Exons where the protein coding regions are, and the introns are the areas in between with regulatory elements and other unknown functions. The exome sequencing works by capturing those exons only and sequencing those parts. The whole genome will sequence every single bit. That's the difference. So the outcome will be that we are sequencing a lot smaller target, and therefore the cost per base in the sequence will be a lot cheaper. And this is the clinical exome sequencing service we do at Troya. And we have proposed at Troya, we have proposed this approach towards clinical exome sequencing. Which test to use, what level. So my suggestion is, if you have a possible diagnosis and you're pretty sure of, and you just need a confirmation of that diagnosis, and you want to screen the genes so you can provide a genetic counseling, a proper genetic counseling to the family, you can go for the basic or expanded option. You can just screen the 4,800 or 7,000 genes, and you come up with a mutation. If you don't have a positive family history, you still can use exome, but you need to expand your search a little bit. This is where the whole exome is useful. Okay, the whole exome is useful, but not on its own only. If you combine it with the chromosomal microarrays, then you will have a whole genome level of analysis. So you can, this kind of selection algorithm can determine the cost and determine the speed, but determined by you. And what happens to the sample when we receive it? Once the request is generated, we perform the DNA extraction from, routinely it's peripheral blood in an EDTA tube. We prepare what we call library generation for NGS. We perform the sequencing. We do the bioinformatics. Here we generate FASTA-Q and variant calling. We annotate those variants. And a team of medical genetics scientists will determine, based on your phenotype you report in the request form, which of these variants is responsible for the disease. And this is where the report is generated with quite a bit of details about the interpretation, the mutation itself, the exact location of it, if you want to use it for your publications or your paper writing. Just to end on a couple of cases, very interesting cases. For example, this case referred to us by Dr. Ahmed Awisnada, where we had a 21-year-old male has a family history of vision loss and muscular dystrophy. SMA was suspected but turned out to be negative. And interestingly, 2 siblings suffering from muscle weakness were there, and other 2 siblings have noticeable decreasing vision. So we performed clinical exome. This panel, we used the smaller panel, the 4,800 gene on it. And what we came up with is quite a complex case of mutations where we find that the patient didn't only have one disease, he had 2 diseases. He had, you can see here, Conrod dystrophy 16, and he had spinocerebellar ataxia 8. So he had 2 syndromes
You'll have
happening
4 minutes.
at the same time.
4 minutes.
We'll be on time.
Okay.
And when we screened the rest of the family, every single member of the family, or the brothers and sisters, we actually segregated those mutations to the phenotype. And one of those children, actually, he started to develop the muscle weakness. Another case study, also muscle weakness, and they're not able to walk with head lag, normal speech and intelligence, myopathic changes observed, necrotic and regenerative fibers is strong, but there was a very strong inbreeding and family history. And this is the family, and you can see almost all the last generation affected by the syndrome. So we used a similar approach, exome sequencing. We have identified the mutation in FKRP gene, and we suggested that the syndrome they're suffering from, or the disorders they're suffering from, was muscular dystrophy, dystroglycanopathy, or limb girdle type C. So we zoomed into the type of limb girdle dystrophy they have suffered. And because we screened the family members as a standard, we managed to segregate the mutation with the carriers and the other cousins of the index case. Case study 3, another FKRP mutation was identified in a family, but this time the report came back with high CK levels. I'm not sure how high, but it was high CK levels. MRI reported cerebellar hypoplasia, and the initial diagnosis was congenital muscular dystrophy. So the same approach identified another mutation in FKRP gene. But from our knowledge, using OMIM, the FKRP mutations are associated with type C muscular dystrophy, limb-girdle muscular dystrophy. Case 4, another case here. In this case, we found GNE as the responsible gene, and inclusion body myopathy. So in conclusion, so far we have identified the involvement of 10 genes in 11 families of patients suffering from various forms of neuromuscular syndromes. The major phenotype on the report was muscle weakness or muscular dystrophy. The other genes include CYP2U1, AMPD2, ITRP1, DNM2, DOC7, and other genes. The initial diagnosis for the 11 families was congenital muscular dystrophy or limb-girdle type, but because we used one test, clinical exome sequencing, we have identified the 10 genes responsible for these 11 families. And in my opinion, my humble opinion, I think clinical exome sequencing should be considered as a frontline testing strategy for neuromuscular disorders, especially if there is a family history or if other variants or if the syndrome itself does not fit all your checklist of symptoms. Because we can do that now because the cost is reduced because we do it locally. We don't have to send out or worry about the cost of send outs. The locally is done to cost. How much it costs us is how much it's costing the patient, and can save the patient from undergoing invasive biopsies in certain cases and help in reducing the burden of genetic disorders in Saudi Arabia by assisting informed genetic counseling and options for preventative pre-implantation genetic diagnosis. So my last slide, hopefully the movie will work. This is just a tour of the labs we are doing all this. This is just a crossroad from King Abdulaziz University, and you're welcome to inquire, and if you want to use the services at any time at your liking. Thank you very much.